My background is that I actually trained here at Case Western in internal medicine and infectious diseases, and as part of training in infectious diseases, we do some travel medicine, and some physicians who specialize in infectious diseases do clinical travel medicine as part of their clinical responsibility. And I work in the travel clinic here. Saw patients today. One of them is in the audience. No, it's probably a HIPAA violation. And I've been doing this for about 18 years. And this says, it says update in travel medicine. I guess it could just be travel medicine, because I think there's a broad range here in the audience of are you guys, the people I don't know, are you medical students or all medical students? Okay, so you guys know what's going on. Travel medicine is a growing field. This is just some statistics. 500 million travelers a year cross international borders. 20 to 70% of travelers from developed to developing areas develop some kind of illness. 1 to 5% seek medical attention. 0.1 to 0.01 requires evacuation, but 1 in 100,000 has a fatal illness. What I'm going to do is kind of review, kind of in general, what we would do for a traveler who comes to our travel clinic, kind of what the key issues are, talk about various information sources, and again, when I work in the travel clinic, a lot of individuals come to me already having been to the CDC website. Occasionally they know more than I do, which is okay. You have to be humble in this business. Talk about vaccination issues, malaria issues, GI issues, and some emerging pathogens. There is a certification in travel medicine that physicians can get. I think you have to do so many hours supervised in a travel clinic, and then take a test and probably pay someone some money. So there's some really terrific internet resources for travel medicine. And the CDC website on travel medicine is actually quite excellent. It's user-friendly, it's updated. For instance, they've put together a really nice 8-page thing. I say 8 pages because I printed it today on travel to Haiti. So I was in a travel clinic today. I saw three people going to Haiti to do medical work or relief work. And the CDC website is excellent, and the other websites, if you're interested, are also really good for travel medicine. So I like to start with a case, and I'll read the case. LM is a 56-year-old interior decorator who spent 6 weeks on the west coast of Baja, California. She and her companion mostly ate meals she prepared, but on one occasion did eat oysters. 10 days after returning to Cleveland, she presented to her primary care physician with low-grade fever, anorexia, malaise, and fatigue. Now I'll stop here and say one other issue about travel medicine. Most of what we do in the travel clinic is pre-travel health care, and it's actually a little bit boring. Again, I want to make like a hologram of myself, because you kind of say the same thing over and over again, and it's not that exciting. What's more challenging as a clinician and more interesting is when people come back sick. So we do see the ill travelers in the travel clinic. That's a small minority of the patients, but those are more challenging in terms of what we do. There's a whole approach to illness in a returning traveler, and there's a diagnostic approach based upon what the symptoms are and what the incubation period is. And so the differential diagnosis is based upon, obviously, the symptomatology, but also based upon the incubation. So this is a traveler who's coming back with relatively non-specific symptomatology of, low-grade fever, anorexia, malaise. And she developed symptoms 10 days after returning. And that's pretty important, because most illnesses that people return with, are usually not significant, viral illnesses that people may pick up on the airplane. Now, you have to cut out the wheat from the chaff in those cases. She got sick 10 days after she got back, so if it's travel related, it's a differential diagnosis. She reported no illnesses in Mexico. Her vitals are stable, and on exam, exam only notable for mild epigastric tenderness. Labs showed a normal CBC and chemistries, but of note, she had an SGOT of 3,900, SGPT of 4,000, GGT of 300, alk phos of 180, total bili of 1.4, and INR of 1.2. So pretty nonspecific symptoms, pretty dramatic lab abnormalities, kind of classic for X. I don't know if anybody wants to throw it out there. So it's pretty suggestive, obviously, of acute hepatitis, probably acute viral hepatitis, and the number one vaccine preventable illness in travelers is hepatitis A. And I guess for the more mature clinicians in the audience, now we have, Dr. Barsini, Dr. Coakley, would you admit this patient? So I guess you missed most of the presentation. I mean, this is sort of an aside from travel medicine, but when you see patients with acute hepatitis A, they can have very impressive transaminases, and that in and of itself is not that significant. They just have a lot of inflammation. The decision to admit is really based upon high-grade fever, nausea, vomiting, and the INR. The INR is really the marker of whether the patient's developing liver failure or not the height of the transaminases. So her INR was slightly up. She was seen in the UHER on a Friday. The chances that she would not get admitted are essentially 0. So she was hepatitis A IgM positive, so she was a proven case of hepatitis A, acquired while traveling in Mexico. Over the next week, the bilirubin peaked at 13. She gradually improved. Again, patients with hepatitis A have this sort of liver injury phase and icteric phase, and she kind of was the classic pattern. Started with high transaminases, and the bili went up. And then her traveling companion got gamma globulin, right? Because presumably he was exposed to the same source as she was, and he was also exposed to her. So we gave him passive immunization with gamma globulin. So, so hepatitis A, as I said, is the number one vaccine preventable illness in travelers, and the incidence is relatively high. So depending on what type of travel you do, and this really goes for all travel medicine, then there's a huge spectrum of risk. So the college student who's hitchhiking around South America, is one level of risk, and the high-end traveler staying in a 5-star hotel in a major metropolitan area is a very different, lower risk traveler. But overall, the risk of hepatitis A is about 3 to 6 per 1,000 travelers per month in resort-type areas. That's pretty high. And for the off the beaten path, it's 25 to 30 per 1,000 travelers per month. And why is that? Why is the risk of hepatitis A so high? So it's important to sort of know about the epidemiology of hepatitis A, and that is that in most countries, infection with hepatitis A in early childhood is ubiquitous, and there's hepatitis A circulating in the community, in the food and water supply. Hepatitis A in small children is generally a mild and non-icteric illness, non-specific. And so people acquire hepatitis A immunity as a child without becoming sick, and they're immune the rest of their life. So people who grow up in areas, in most countries in the world where hepatitis A is common, acquire immunity as a child, never have a clinical case, and never have to worry about having a severe case when they're an adult. The people at higher risk are the non-immune travelers who go to the endemic countries. Because they lack the immunity, they didn't acquire immunity in childhood. And hepatitis A is a more severe illness in adults. It's again, not normally fatal, but it can be fatal in some cases. So the adult Western travelers from the United States, Canada, Western Europe are non-immune and high risk for acquiring hepatitis A. And if people come to travel clinic, we would immunize people against hepatitis A for almost anywhere in the world except Canada, Western Europe, New Zealand, Australia, Japan. Everywhere else in the world, we give hepatitis A. If you're going to go to Cancun, on a package tour for 5 days, you're probably not going to go to a travel clinic. But if you did go to a travel clinic, we would give you hepatitis A, vaccine. So people going to Mexico on spring break, if they asked us, we would say you should get hepatitis A vaccine. So it's very common. It's a 2-shot vaccine. So again, this is part of the spiel. I wish I could have myself recorded because you heard this today. One shot gives you full protection, but it only lasts for a couple years. If you get the booster, it's then good for 20 years. Typically, what travelers do is they come to travel clinic 2 weeks before they travel. They're focused on travel medicine. They get a hepatitis A shot. They're protected for that trip. They never come back and get the booster. 3 years later, they're going on another trip. They come to the travel clinic and say, we've got to start over because you missed the booster. So the package insert says the booster should be given between 6 and 12 months. The studies have shown that it's good up to 18 months. If you get so the first shot gives you protection for about 2 years. The booster makes it good for 20 plus years. The other issue, this may be in the next slide, is people ask about, well, what if I'm traveling in 3 days? Because in theory, if you think about a vaccine, it takes a while to develop protective immunity, protective antibodies. Well, studies have shown that if you get the hepatitis A vaccine on the way to the airport, it's protective. It probably has to do with the fact that there's a long latency period, a long incubation period for hepatitis A, and that you develop antibodies relatively quickly, and you're protected. There's the hepatitis A vaccine, and then there's a combined A/B product called Twinrix. So if a traveler comes and they need A and B, and we'll talk about B a little bit later, I think, but if they need A and B, you can give them A/B at the first dose. 1 month later, they get just B, and at 6 months, they get A/B. So they get 3 shots instead of 5 shots, which people like sometimes. Yes, FDA labeling, give 2 weeks prior to exposure, but effective on the way to the airport. And booster is good for at least 15 years. We don't. I mean, I think it's not like hepatitis B would in healthcare set. What's that? The hepatitis B? That's a great question, and I don't. In all the years I've worked in travel clinic, we've never done that. I think it's. The hepatitis B, I'm not a vaccinologist, but obviously the hepatitis V takes 3 shots and must be more of a challenging, virus to raise protective immunity against. Hepatitis A. Hepatitis A is it's really a relative of enteroviruses. Enteroviruses is a family of viruses that cause hand, foot, and mouth, pleurodynia, aseptic meningitis. Polio is an enterovirus. They're small RNA viruses that enter through the GI system, don't cause GI disease, and then you become viremic, and there's a tropism. So polio is an enterovirus that goes to the spine. Hand, foot, and mouth is an enterovirus that causes ulcers. Hepatitis A is an enterovirus that goes to liver, and I think it's pretty easy to get protective immunity against that type of virus. I'm going on a limb by saying that, but we don't draw titers. So. Right. Right, yeah. Not like hepatitis B, yeah. So the hepatitis B issue is interesting because for years the CDC only recommended hepatitis B in travelers who are going to be living in an endemic area for more than 6 months or would have exposure to blood or body fluids. And so most travelers who I felt needed hepatitis B were medical people, nurses and doctors, who already had hepatitis B immunization. And every once in a while there would be someone who would be moving to Thailand or moving to China, for a long period of time. We would give them hepatitis B immunization. The idea is that if you're going to be living someplace in an endemic area for a long period of time, it's more likely you'll come into contact, through intimate contact with hepatitis B. A couple of years ago, the CDC started recommending more liberal indications for giving hepatitis B to travelers. And I think that those of us, my colleagues in the travel clinic, Dr. Slotto, Dr. Bobak, we still don't really do that. We really give it to high-risk people, people who will be involved in medical work and they've all had it, or people who are going to an endemic area for a long period of time. When we see people in travel clinic, we do, depending on who they are and where they're going, we do mention risk of things like HIV and hepatitis B in certain parts of the world, and give that kind of counseling. So if the traveler in the case had come to travel clinic, and again, she was spending 6 weeks in Mexico, what would we have done? Well, everyone who comes to travel clinic, we ask them about tetanus. And most adults don't know when the last tetanus shot was. And so I guess travel clinic is an opportunity to update people's tetanus. Again, what's the schedule for adults? I mean, adults should have a tetanus booster every 10 years. The reason we emphasize tetanus in travelers is because you don't want to step on a nail in a rural part of a developing country feel like you need a tetanus shot, go to some sketchy clinic and get a sketchy tetanus shot. So it's better to be, be sure you're immune to tetanus. Yeah, the only downside to tetanus is it causes pain in both buttocks. What I mean by that is most travel clinics charge the individual cash. So if you come to travel clinic, you pay cash for the tetanus vaccine. If you get the tetanus vaccine through a health center or your doctor, they'll probably pay for it. Plus there's the shot, that's the double pain. So travel, our travel clinic, you didn't get charged today, right? We're starting to charge insurance.
I don't know. I just came up to them and they said, usually when I go, if I have the cheapest insurance,
Yeah. Yeah.
I said, well, it doesn't say anything on my card, so they didn't charge me.
Yeah. It's funny, starting Monday of this week, starting March 1st, I guess yesterday, we started, and up until I've worked in the travel clinic since 1992, before many of you were born, and we always charge cash because travel medicine is considered a luxury, like plastic surgery, and so it wasn't covered by insurance. And I'm not sure why, but as of March 1st, our Department of Medicine, our hospital decided we are going to charge insurance. So I saw a resident from another department today who's going to Haiti, who scheduled his travel clinic visit knowing that starting Monday that it would be covered, we would charge insurance. So, but we started doing this on Monday. I gave you the big discount. I gave you the secret discount. Don't tell anybody. Yeah. So if she'd come to travel clinic, we would have asked her about tetanus. We would have, without question, given her hepatitis A. We would have inquired about typhoid. Now, typhoid, I'll talk about in a few minutes. It's the one vaccine where there's the most gray area. One of the things that happens with typhoid vaccine is you'll have a discordant couple in terms of what days they come to travel clinic, and they'll see two different travel doctors, and one will get typhoid and one won't, and then we'll look like idiots. But when I talk about typhoid, the recommendations are vague. Now, the other issue that comes up in travelers is measles and polio, and there's not a lot of measles in the Western Hemisphere, not a lot of polio, but there have been outbreaks of polio in the Caribbean. So what's the issue with measles? So this is like a quiz question. People born before what year in the United States are all naturally assumed to be immune to measles? So people born before 1957, that would be 1956 and before, can safely assume to have had natural measles. Sorry. So everybody born before 57 had measles, and then there's a window period between 57 and the early 70s when the way people are immunized left them vulnerable as adults. And starting and this was recognized, and starting at least in the 70s, the recommendation became for a live measles vaccine, in after early childhood, and that gives you immunity for life. So in the last 20 or 30 years, I'm sure all of you in the audience who are relatively young, you probably had MMR and in a relatively older age, not early childhood. But there's a group of individuals who are immunized against measles in the 60s and 70s, who may have lost their immunity as adults. And measles is so rare in the United States, it's not an issue, but if they travel to a measles endemic country. So in the travel clinic, you see someone born in the 60s or 70s who's going to countries where measles is still found. We give them a once in a lifetime measles boost. And the same for polio. Adults in the United States may have lost their polio immunity by the time they're in their 30s or 40s or older. So we'll give people a once in a lifetime polio boost for international travel. So that's most of the immunizations. I'll get back to some. Any comments or questions? Okay, this is case 2. This is a patient who was admitted to the Carpenter team a couple years ago. A 46-year-old woman who presented with 10 days of diarrhea, hypotension, and acute renal failure upon return from Cape Verde. She denied fever or abdominal pain. She had frequent watery stools. In Cape Verde, she was given nalidixic acid with no improvement. Nalidixic acid is a quinolone, but it's not a fluoroquinolone. It's an original quinolone that's not fluorinated. This is where Cape Verde is. These aren't lousy pictures, I'm sorry, but we've had 2 Cape Verdeans admitted to UH. This lady, and we had a lady that had babesia. If you recall, she was from Cape Verde, but she lived in Massachusetts. There's a lot of Cape Verdeans that live in like New Bedford, Massachusetts, and she came to UH. So she had a creatinine of 4.8. Her CBC was normal. So this is an interesting lady. So she had hypertension, diabetes, was on an ACE inhibitor and a diuretic, which probably, and she was intravascular volume depleted. So that's probably, I know we have a renal fellow here. You can just go with it. I know it's yeah. But so this lady developed diarrhea after she got back, and she was taking an antibiotic, and she came in with this kind of dramatic presentation with renal failure, and her abdominal exam was pretty benign. So what would your diagnosis be? Well, I saw this patient on a Friday night at 5 o'clock, on the Carpenter team, and I thought she was going to have Giardia because she had more persistent symptoms. She had watery diarrhea. She had a pretty mild exam, and she was taking an antibiotic. And Giardia is the most common cause of traveler's diarrhea that begins after people return because it has a longer incubation than the other common cause of traveler's diarrhea. Now, her began there. And there's a really simple test to help you in your differential diagnosis of any acute diarrhea, particularly in a traveler. And again, international travel is a big risk for bacterial gastroenteritis. That's one of the questions you always ask anybody who's presenting with acute infectious gastroenteritis. But the tests that you can do that can help you differentiate the different causes of diarrhea are fecal leukocytes. And no matter how I try, I seem to have a hard time getting residents enthusiastic about fecal leukocytes. But in this case, we took some of her stool over to the micro lab, and it's a very easy test to do. You put a little stool on a slide, put a cover slip on, put a little drop of dye next to it, kind of goes under by capillary action, and you look for polys. And polys are very easy to see at even relatively low power. They stand out. They're dramatically different cells. So when we looked at her stool, we saw sheets of polys. So what does that say about Giardia? Giardia is small bowel non-inflammatory. It doesn't cause colitis. It causes malabsorption. It causes osmotic diarrhea, but does not cause inflammatory diarrhea. So that was interesting. So we saw these polys. And I don't know what the next slide says, but she grew a bug, and the bug she grew is now probably the second most common cause of traveler's diarrhea worldwide. It's now the most common cause of traveler's diarrhea in Thailand and other countries in Southeast Asia, and it's the most common cause of bacterial gastroenteritis in the United States. So Campylobacter, yeah. And so she grew Campylobacter, which was interesting. And again, Campylobacter is notorious for being quinolone resistant, and nalidixic acid is, so this kind of made sense. She didn't get better on nalidixic acid. So there's a little bit about traveler's diarrhea. Traveler's diarrhea is it's a syndrome, acute gastroenteritis or acute gastrointestinal infection acquired from travel. And there's a like any syndrome, there's a variety of causes. The most common cause of traveler's diarrhea is enterotoxigenic E. coli. So enterotoxigenic E. coli is a pathogenic strain of E. coli that Westerners are not accustomed to or immune to, that causes disease by having determinants to cause adherence and toxin production. And it causes diarrhea much like, not to the extent that cholera does, but it causes diarrhea by toxin production that interferes with the absorption and metabolism of solutes in water, so you get watery non-inflammatory diarrhea. And enterotoxigenic E. coli is, again, the #1 cause worldwide of TD, as we say in the biz. And then Salmonella, Campylobacter, Giardia, Cryptosporidium cyclospore, other pathogens. There's a fundamental difference between the way we acquire gastrointestinal pathogens in the United States, bacterial gastrointestinal pathogens, and then developing countries. In the United States, we have quite a few cases of Campylobacter and Salmonella, and the source is agriculture. So it comes from animal sources to human beings through food. In the developing world, the source is food and water contaminated by human waste. So the food and water supply is not safe. There's contamination, and that's how we get disease. And E. coli is number one. It's important to understand the mechanism of action of E. coli, because one of the kind of paradoxes about the way we approach traveler's diarrhea is that us ID doctors are advocates for treating traveler's diarrhea with antibiotics. But if you ask the same ID doctor, or if someone shows up in your clinic and you think they have acute bacterial gastroenteritis and they're otherwise healthy young adult, they might have salmonella, they say, don't treat. No indication to treat, doesn't make them better. So on the one hand, we recommend aggressive therapy for traveler's diarrhea. On the other hand, most ID doctors are very cautious about any real utility in treating someone here in Cleveland who has, who ate a bad burger at the Rascal House and has, is this being taped, is it? No, just kidding. Who has, salmonella. Exactly, yeah. And there's two reasons for that. One reason is that, travelers are kind of vulnerable and, the access to medical care is different. But the big reason is treating traveler's diarrhea with antibiotics is effective, and treating generic salmonella gastroenteritis isn't very effective. And so why is that? So this is a question that I used to ponder when I showered in the morning. Why is that? I would think, well, if you think about the mechanism of action, the mechanism of action of ETEC, the number one cause of traveler's diarrhea, is the elaboration of a toxin, and you get excretion of fluid and solutes, and you get an osmotic diarrhea. You give an antibiotic, you stop toxin production, the whole thing turns off pretty quickly, right? The mechanism of action of Salmonella enteritis, the non-typhoidal salmonella, is colitis. So by the time you have symptoms, you have a significant inflammatory process going on in the bowel, and no matter whether you give antibiotics or not, that's going to take a while to kind of damp down. And no, you don't do anything. I mean, again, it's thought that, that in the 1990s, salmonella was the number one cause of bacterial gastroenteritis in the United States. This is salmonella that comes from chickens, cows, food, all kinds of food can carry salmonella. And I think the consensus was that if someone was otherwise young and healthy, there was no real indication to treat. If someone's immunosuppressed, sickle cell patient, steroids, Rituxan, we're going to treat that patient. But whereas we treat the travel patient. Now in the United States, I think in the last 10 years, Campylobacter has now surpassed salmonella as the number one cause of bacterial gastroenteritis. And it's controversial whether you treat those patients or not. That most of them are self-limited. So, but travelers, there's a very strong indication to treat. Okay, I guess I talked so long this thing froze. Oops. Okay, so now it's going to pop back and forth. So I may have to adjust the slide. So we have a, yeah, what did I say? We have a very standard approach in travel clinic. Again, this is where I wish I could just digitally record myself and play it over and over again. But so when people come to travel clinic, we have a standard spiel about avoiding getting traveler's diarrhea by avoiding contaminated food and water. And it's a pretty specific, it's a pretty generic spiel. And it's no water unless it's bottled or boiled. It should be bottled water where you break the seal yourself. Coffee and tea are okay. Soda pop and juice are okay as long as it comes from a sealed container. No ice cubes. No tap water in a mixed drink. Don't brush your teeth with tap water. Don't drink the water in the shower. Most people do okay with bottled water. It is important to drink bottled water where you break the seal yourself. I've seen a few travelers where, I don't know why it happened in China, where it was an elder hostel group, and one guy buys a bottle of water from a kid by the road, standing on the road, an unsealed bottle of water, drinks it and gets sick, and lo and behold, probably the enterprising young lad filled up a bottle with tap water. Anyway, so the water side of things is relatively easy. The other big pitfall is eating something raw. So basically, we tell travelers, don't eat anything that's not cooked unless you peel it yourself. If it's not cooked and you can't peel it yourself, don't eat it. And that's the number one thing that probably gets tourists to go to Mexico. They drink bottled water, but then they get a hamburger with lettuce or salad. Big no-no. And again, there's a huge gradation of risk. So eating raw food from a street vendor is an invitation to an interesting gastrointestinal experience. You know, eating the mango at the five-star hotel's breakfast bar is probably relatively safe, but not zero. So anyway. So when we see travelers, we talk about avoidance of acquiring traveler's diarrhea, and then we do what's called presumptive therapy. So we give them an antibiotic, and we give them Imodium, and we say, if you get diarrhea, do self-treatment with both an antibiotic and Imodium. And again, it kind of flies in the face of sort of dogmas in the ID world. There's a sort of dogma in the ID world that you can't give Imodium to anybody that has diarrhea because maybe they have inflammatory diarrhea and you'll get a toxic megacolon. And that's probably not true, except for maybe severe cases of Shigella, that sort of thing. But for travelers, we give Imodium and we give an antibiotic. And again, part of the idea is that if you take the antibiotic with the Imodium, it's a safe situation. But just as an aside, because I find this really interesting, there's a clinical trial going on right now for using Imodium in C. diff. Again, it kind of seems anathema that you should slow down peristalsis in C. diff. But when people looked at the data, they thought there's really no data. And so there's a clinical trial of using Imodium in patients with C. diff because a lot of the morbidity comes from diarrhea. Now, all those patients are on treatment. So no one's recommending using Imodium in patients with C. diff not on treatment. So, do you mind calling the transfer center and asking them to page the chief? Just 844. If you can figure out how to use my phone. It's the droid, 844-11111. Yeah. So we typically give Cipro, although Zithromax, believe it or not, which people think of Zithromax as the Zithromax is the antibiotic for a young urban professional who has a viral URI but demands an antibiotic, right? That's how we use Z-Pak. It was a joke, but it's actually very effective for Campylobacter, and as I mentioned earlier, in Thailand, for instance, 90% of travelers' diarrhea is now Campylobacter, and 90% of that's quinolone resistant. For Southeast Asia, we've abandoned Cipro, and we give Zithromax. And some traveler doctors are going to Zithromax first. I guess we still use Cipro for South America, Africa, and South Asia. That's an excellent point, yes. Cipro, because cost matters, right? Yeah, it's free. It's free, yeah. Yeah. There's Giant Eagle and one other place there's 10 free antibiotics. The funny thing with patients is, if you give a patient a prescription for one of the free antibiotics, they think it must be no good. But anyway, some patients. But so we give presumptive therapy, and this approach has been studied. So there's a couple ID guys who kind of made their career by doing clinical trials of traveler's diarrhea, and they would do clinical trials in college students going to Mexico on spring break, and there would be like the Pepto-Bismol arm, the presumptive therapy arm, the preventive therapy arm. So there's pretty good data on these approaches, and Pepto-Bismol does work. The problem with Pepto-Bismol is you have to take it really around the clock, and I'm exaggerating, at least 3 or 4 times a day, which is pretty inconvenient for travelers, and there's some downside to taking Pepto-Bismol. So I think the approach that we use for traveler's diarrhea is obviously the avoidance approach, but then the presumptive therapy approach. And it's not preventive therapy. Preventive therapy is not appropriate. So taking a Cipro a day to prevent traveler's diarrhea is not considered good medicine. I know a few physicians who've done that. But presumptive therapy is the way to go, and avoidance. There's a new drug that has been marketed, rifaximin. It's a non-absorbable oral therapy for traveler's diarrhea. It's approved by the FDA for prevention of E. coli traveler's diarrhea. It doesn't get Campylobacter very well. I think the company that makes this drug was trying to stir up interest in a preventive strategy versus a presumptive therapy strategy. And one of the angles that they're trying to play up is that if you think about traveler's diarrhea, it's a self-limited illness in most patients. There's some data that, they said okay? Thanks. Well, 1-800-ROSCOE. So, sorry. There's some literature that suggests that people who get otherwise self-limited gastroenteritis have a higher incidence of irritable bowel syndrome after they recover. So the makers of rifaximin, I think we're hoping that people would embrace that and embrace a preventive strategy versus a presumptive strategy. Because even with the presumptive strategy, you do have what is hopefully a very self-limited bout of gastroenteritis, but it's a bout. I've not used rifaximin very often. One of the tricky issues, again, we really see two types of travelers. We see the business or young traveler, but there's a lot of affluent older travelers, and a lot of them have complicated medical conditions. And so if someone's taking warfarin, for example, and the last thing you want to do is someone's taking warfarin for AFib, the last thing you want to do is put them on Cipro when they're not in a place where they can get their INR checked. So again, you might start them on rifaximin, which is not absorbed, and get a steady state before they leave, that kind of thing. Or use Zithromax is probably not quite as bad for the INR or Cipro, but none of those. What I do with patients who I end up giving Cipro who are on warfarin, I tell them to cut the warfarin dose in half. Is sort of the best you can do. Again, there's some unique geographic associations. So Cyclospora, which is a protozoal pathogen, is very prevalent in Nepal in the rainy season. So that's a bug that responds to Bactrim, trimethylene sulfa. So a different approach. And I mentioned the Campylobacter in Thailand is now by far and away number one. Talk about a couple of vaccines. I mentioned typhoid fever. Typhoid fever is the vaccine where the CDC recommendations are the most vague. So the CDC recommends typhoid fever for trips of longer than 3 weeks, people with adventuresome eating habits, people with staying with friends and friends of family, or people who desire maximum protection. So it's very vague. So if someone's going for more than 3 weeks, it's pretty easy to give typhoid fever. People taking short trips, it's hard to know what the right thing to do is because the risk of typhoid fever is very low. The vaccine is only about 70% protective. It doesn't protect you against Salmonella paratyphi. And the number needed to treat is quite large, but we still give it. Actually, since I've been here in our travel clinic, I've seen 2 cases of typhoid fever. Both were Salmonella paratyphi. One was a young woman who acquired it in Cancun, which I really got a kick out of, because Cancun is like Miami in Mexico, but she had gone from the resort of Cancun to the city of Cancun and eaten a hamburger with lettuce. And I don't know if that's the source of her typhoid fever, but it certainly could have been. The other case I saw was someone in Srinagar, in North India, who got Salmonella paratyphi. Neither of the 2 cases I've seen, neither would have been protected by the vaccine. But we still give the vaccine because there is a risk. And as people, in general, expats returning home are the highest risk for everything. That's one of the principles of travel medicine, is people who are expats or traveling back to visit friends and relatives are higher risk. Because I saw a guy in travel clinic today who grew up in Liberia. He's not been back for 10 years. He's traveling back. The fact that he came to travel clinics is sort of extraordinary because a lot of, especially West Africans have the highest rate of malaria of any. Returning expatriate West Africans have a very high rate of malaria because if you grow up in a country like Liberia, you kind of take for granted that people occasionally get malaria and do okay if you survive childhood, that is, and you become immune to all the usual gastrointestinal pathogens and. But if you leave 10 years, you lose all that immunity. So returning expats and families of returning expats are a high-risk group. And they're a high-risk group for typhoid fever because they're eating with friends and families. Their food and water precautions are different than people who are staying in hotels. So, Japanese encephalitis is a tricky one. Japanese encephalitis is a mosquito spread virus that's similar to West Nile. And like West Nile, there's a lot of mildly symptomatic cases or asymptomatic cases, but there's the occasional fatal case. And it's the risk of Japanese encephalitis virus is primarily during the rainy season in rural Southeast Asia, primarily. And so if you see someone in a travel clinic, you've got to figure out, are they going to be rural or urban? And then make sure, look in the CDC book, make sure that it's not one of the few urban areas where they see Japanese encephalitis virus. And then is it the rainy season or not? Because the risk is extremely variable based upon the time of year. And it's an important question because it's 3 shots, it's pretty expensive, and there's a downside. So the serious adverse event rate is about 1 or 2 in a million. If you take all travelers to Southeast Asia, the risk of Japanese encephalitis virus or serious cases is about 1 in a million. So obviously, that's not good. So you need to really pick those patients carefully. Travel in a rural area during rainy season. I mean, I saw someone last year who was going to be backpacking around Southeast Asia during the rainy season. They needed Japanese encephalitis virus vaccine, pretty high risk. Someone who's going to Kuala Lumpur for a business trip for a week does not need Japanese encephalitis virus. Again, part of the art of travel clinic is it's not all just looking it up in a book. It's kind of knowing where people are going, what they're doing, what their risks are, and trying to figure it out that way. Meninge is one that we give. There's an area of sub-Saharan Africa that's called the meningitis belt, where there's frequent outbreaks of meningitis, and so we give meninge. It's actually a part of southern Nepal that's considered a high-risk area for meninge. And so especially people who are doing medical work in sub-Saharan Africa, particularly in sub-equatorial Africa, we give the meningitis vaccine. Some people going to India and Nepal, we give. The meningitis vaccine is now required to go on the Hajj. So the Hajj is obviously religious pilgrimage to Medina and Mecca. So you can go to Mecca during the times of year that are not the Hajj, but if you go during the Hajj, you can't get a visa without proof of meninge. And then now require the quadrivalent vaccine, the most modern meningitis vaccine. Again, there's a whole thing in vaccinology where if you vaccine against a bunch of serotypes, you'll see the rise of another serotype. This happened with pneumococcus in the United States. This happened with meninge. So there was a standard meningococcal vaccine that didn't include the one serotype, and people were getting this before they went to Saudi Arabia on the Hajj. And then in the year 2000, there was a big outbreak with the serotype not included in the vaccine, and now there's a new vaccine that includes the serotype. And actually, in our travel clinic, we see a fair amount of travelers who are going on the Hajj who come they come primarily because they have to have a card stamped that says they have meningococcal vaccine. The other Hajj issues are hepatitis A and B. Even though the Saudi authorities do a pretty good job of public health, part of going on the Hajj is ritual shaving. And so that's a risk for hepatitis B, with shaving, and hepatitis A because it's just a crowded condition with millions of people from all over the world. We also immunize against, we give pneumovax and influenza because people are living in crowded conditions and spreading these bugs from around the world. And again, the Hajj is sort of it's an ID scenario. Millions of people come from all over the world in crowded conditions for a couple weeks, right? So yellow fever vaccine is the only vaccine that's required. So back in the 1970s, some countries required cholera. I don't know if I have a slide on cholera, but cholera we almost never give cholera. It's a crappy vaccine, so to speak. It offers poor protection, poor duration of protection. It's a treatable disease. The risk is relatively low. And I think the WHO in the late 1970s, early 1980s, got all the countries in the world to agree no one was going to require cholera anymore. So the only vaccine that other than, the meninge for Hajj, but the only other vaccine that's required is yellow fever. A lot of countries require yellow fever for entry. It's kind of unpredictable. A lot of countries require yellow fever for entry if you've been in another country that has yellow fever. So for instance, you may go to Brazil and you may stay in an urban coastal area, but your itinerary may include Peru, Argentina, and Colombia. Well, if your passport says Brazil, one of the immigration officials in Colombia, Peru, Argentina may say, "Where's your yellow fever proof? You've been in Brazil." So yellow fever is the one that people come for the clinic just because they feel like they need it. The risk of yellow fever, there's really two areas in the world where there's yellow fever. There's sub-Saharan Africa and equatorial South America. In South America, it's predominantly rural. There's almost no urban there's essentially zero urban transmission. You agree? Yeah, someone who studied there. And in Africa, however, the transmission of yellow fever is both urban and rural. So again, if someone's going to go on a business trip to Colombia, the last thing they need is yellow fever vaccine. If they're going to go off on a very, oil exploration or something way off the beaten path in a rural area that's at lower elevations, then they probably need yellow fever vaccine. Again, the source of yellow fever in South America is primarily from animals to humans. In Africa, it's both animals and humans to humans. It's a live vaccine. It's good for 10 years. So when people come to a travel clinic, they get one of those yellow WHO cards, and we stamp it, and there's all kinds of official stamps and signatures to make show proof of yellow fever. It says, if you go to the CDC website, it says it can only be given in specialized centers. So I always thought we were pretty special that we give it. But a friend of mine moved to Baltimore and set up a travel clinic, and he called the state medical board. What kind of requirements do you have for yellow fever? And he goes, "Do you have a valid Maryland license?" "Yep, you're in." So it wasn't that specialized. The yellow fever, again, it's a live attenuated vaccine. There are some adverse effects. The serious adverse event rate is about 2.4 per 100,000. There's about 200,000 doses per year in the United States, so it's not insignificant. And the adverse event rate is much higher in immunosuppressed, and especially the elderly. The older you are, the more likely you are to have an adverse event from this live attenuated vaccine. Again, one of the challenges in travel clinics, people come who are immunosuppressed, people come who are on Imuran, they're on steroids, they're HIV. In general, we don't give them yellow fever vaccine because because it's a live attenuated vaccine. We're concerned about adverse events. When elderly patients come, it's tricky. It's actually advantageous to have had the yellow fever vaccine when you're young. So the adverse event rate for the yellow fever vaccine is almost 99.9% in the first dose because you get partial immunity. So subsequent doses are almost never associated with serious adverse events. I've had it, yes. So if someone comes to travel clinic who's over 75 and they're going to South America, you really got to ask yourself, is it worth giving it to them? Because the risk is so low depending on where they're going. Again, if you take a cruise up the Amazon and you spend the night on the boat, the risk is pretty low. Now, I saw a guy in travel clinic today who works for a company based in Cleveland that does mineral exploration, and he was going to be spending 3 days and 3 nights in some really rural area in Brazil. And he probably needs yellow fever vaccine. I mean, unequivocally need a yellow fever vaccine. The businessman or woman who goes to Rio de Janeiro does not need yellow fever vaccine. Now, if their passport says Brazil and then they try to go to another country, sometimes we give it if they have a really complicated itinerary. And there's some places that require it, absolutely. And I didn't bring it tonight, but the CDC publishes a book, and it also has it on their website. But they have a very nice book. They have yellow fever recommendations for every country in the United States, and it says required for all who enter, required if entering from a country that's listed as having yellow fever, or not required at all. So you look in that book because you can't memorize it. So. Some of the things that I do for elderly patients is, if you're worried that an elderly patient has really almost no risk of yellow fever, but without that yellow card may be denied entry someplace, we'll either give them a letter or just stamp the damn card and not give them the vaccine. Again, this is not on tape, right? I don't want to. So I've worked in the travel clinic at UH, again, almost 20 years or 18 years. And in the last 18 years, I've given rabies vaccine twice. And the reason for that is that the risk of rabies for travelers is low. And rabies has a long incubation. The incubation for rabies is probably weeks in most cases. It's almost always many days. There was actually a fascinating article, interesting idea, a few people interested in idea in this room, a fascinating article in the New England Journal a few years ago where they published 3 cases of rabies in immigrants. And now with modern molecular biology, you can tell what animal and what country rabies came from, by doing, by genotyping. So there's 3 immigrants in the United States who had rabies, and they'd all not returned to their country for a long time. And the latency from exposure was for one guy was a year. And it was more than 6 months, and so rabies has a long incubation. And as long as you receive post-exposure prophylaxis, you're at 100%, before you have symptoms, it's 100% curable. So what we tell travelers for rabies is that if you get a dog bite or an animal bite, I don't know about monkeys in India, they can cure rabies, right? If you get bitten by a monkey in Mumbai or a dog in Tebi, don't ignore it, but don't panic that minute. You have some time. You can call the U.S. Embassy, get directed to a reputable provider of rabies post-exposure immunoglobulin, and get the prophylaxis. The pre-exposure treatment is expensive and painful, and it's overkill. And we almost never give it. The 2 times I've given it was a young woman who was going to be in very rural Africa who felt like she didn't have access to health care for several weeks, which is pretty rare in this day and age. And then last year I saw a couple that was working with Veterinarians Without Borders who were going to be immunizing dogs in India against rabies. Okay. They were high risk. But you have a question?
Yeah, so how long after they get in, should they, how long until they should go to healthcare such that they can be like, well, I'm going home in 5 days, I'll just wait till I go home?
Yeah, and the question was, how long should you wait, or if you're going home in several days? I think in general you probably want to get treated within 2 or 3 days just to take no chances. But most people can get to an urban area, urban areas in Africa, urban areas, and obviously, probably Africa is probably the one. In Asia now, and all through Asia, there's highly advanced medical centers in every large urban country, and even Africa, most large urban areas have some, country. But there's probably no place in Africa that isn't. You can't travel to Johannesburg in one day. I don't know, Peter, you're in Africa, hand of sorts. Addis Ababa, Johannesburg, Cairo within a day or 2. Nairobi, yeah. Oh, yeah. So there's a cautionary tale of a traveler that was published a few years ago. It's a young woman, I think she was 28 or 30 years old, and a very experienced traveler. And she was in Kathmandu and was bitten by a dog and didn't do anything about it. Returned to Boston, where she was from. 6 weeks later, started having symptoms, admitted to, man's greatest hospital, and got sick quickly, and despite heroic efforts, died of rabies. And there was a 6-week period when she could have got post-exposure prophylaxis. That's the tragedy you want to avoid, obviously. That's the goal. But I almost never give rabies vaccine, but I tell people don't ignore a dog bite. That's the main thing. Because maybe she was just nipped by a dog, and it's no big deal. When you're 28, right, you feel like you're immortal. So any questions on vaccines or comments on vaccines? So I think that guideline is, the question was the guideline for rabies vaccine, how soon should you get it? I think that guideline is extremely conservative. I think 1 or 2 days is very reasonable. So that's my recommendation.
And in which case, if you're pre-vaccinated, you still have to go and get further vaccines within 2 or 3 days anyway. So
right, and you still, if you're pre-vaccinated, you still have to get post-exposure prophylaxis. Post-exposure prophylaxis for rabies is a nightmare, and it comes up in the ID world. This is travel-related, but what do you do, for those of you interested in ID in the audience, a few of you, what do you do, this is a phone call you hate to get. It's 10 o'clock at night and your neighbor calls you up and says, you know what, we found a bat in the house. We're scared to death. My kids are scared. Should we worry about rabies? It is a horrible question. It's a horrible question because the risk of rabies is not zero, but it's damn low. But there was a case in the United States, this is a case that's really influenced what we do. The case in the United States of a little girl in Connecticut who died of rabies. And when they went, it was a bat rabies. And when they went back and talked to the family, the little girl had never reported a bite, but the parents had found a bat in the house, and this bat had had access to her bedroom. So the idea was that she was bitten in her sleep and didn't know it and didn't report the bite. So the dogma is for kids that if a bat is found in a house and that bat has access to a child's bedroom, then you should immunize. Why is that funny? And no, but the post-exposure prophylaxis is elaborate and expensive and painful. So it's not trivial, that's all. It's not trivial financially, I mean, it's not trivial logistically, and it's not trivial with the amount of pain and suffering that kids go through when they get all those big injections of immunoglobulin. So, anyway. I found a bat in my house, and I was pretty sure it wasn't near my kids, and we did nothing. So, but a neighbor of mine, you know, he's a physician, and he, you know, they freaked out, and the shots were so painful. They like hold their kids down. You know, it was just horrible. You know, you can just imagine. So, okay. Any other shots on immunizations, vaccines? So, case 3, switching gears to malaria. A 42-year-old woman from Eden Prairie, Minnesota, went to Kenya on a 3-week safari. Prior to leaving, her family friend / physician prescribes chloroquine. And she probably had heard bad things about methylquine and didn't want to take it. And maybe she was going to buy something when she got there. All big mistakes. After returning from Africa, she joins her sister's family in Sanibel, Florida. About 10 days after returning, she develops fever, fatigue, and presents to the local ER. She is admitted to the local hospital in Fort Myers and is diagnosed with Plasmodium falciparum malaria within a few hours of admission. She has a rocky course and expires after 4 days in the hospital. The family is suing the hospital and doctor in Florida. And this is a complicated case. This was in the CDC, in MWR, and I also have knowledge of this case, you know, from being a consultant to one of the attorneys, just to give an opinion about it. And it's a classic case of malaria for 2 reasons. One is she took the wrong prophylaxis, and 2 is she delayed seeking medical attention after she got back, and by the time she sought medical attention, she was pretty sick. So I mentioned earlier that hepatitis A is the #1 kind of target for vaccines, the #1 vaccine preventable illness. Malaria is probably the other really big focus in travel clinics because non-immune adult travelers can die of falciparum malaria. American travelers die every year of falciparum malaria. Not so much 5X, unless you're running a grant, but like Dr. King. So incorrect prophylaxis is not uncommon. So one of the reasons to go to a travel clinic is hopefully someone in that travel clinic knows what they're doing when it comes to malaria prophylaxis. That's where people who don't do travel medicine, you know, don't kind of stay in touch with what's going on, can make mistakes. That's where the family doctor is probably better off sending a patient who's going to a really high-risk area for malaria to a travel clinic where they really know what they're doing. The second bullet is malaria the mime. When you're in medical school, which some of you are, you kind of learn in medical school that malaria presents in a certain way, you know, tertiary fever, quaternary fever. It doesn't happen that way. The whole classic fever pattern are an immune host. Non-immune hosts present extremely heterogeneously. And the only theme that patients have with malaria is they have fever. But patients with malaria come in with fever and headache, fever and diarrhea, fever and cough, fever and abdominal pain. So it mimics other illnesses. And so a lot of classic cases, you know, missed malaria are for people who are worked up for meningitis. We saw a case here a few years ago where a patient almost went to the OR for an acute abdomen until someone, you know, figured out she had just returned from Nigeria. And by the way, the husband and kids are also febrile, and maybe we should think about malaria. It's a true case. So people miss malaria because they don't think about it. And particularly when travelers are back for a while. And that's particularly an issue with incorrect prophylaxis, because there may be some partial protection from incorrect prophylaxis. And someone's been back a week or two, they're over their Africa trip, they're back in the United States, they get a febrile illness, they think it's a viral illness. They go to the emergency room. The patient doesn't tell the doctor that they just came back from Africa 3 weeks ago. The doctor doesn't ask. Unless you look up for malaria, you don't think of it. So one of the most dramatic cases I had here was a woman who returned from a honeymoon in Kenya. And this was before Mount Sinai closed. This is a long time ago. She goes to the Mount Sinai ER on Saturday night, severe headache and severe fever. They did a CBC, they did a CAT scan, they did an LP, all negative. They discharged the patient. Monday, someone looks at the smear and says, oh my God, there's all these parasites there. They admit her to UH. She's got 25% parasitemia, exchange transfusion. She did okay, but a very dramatic case. So there's basically 4 drugs that we use in the United States to prevent malaria. There's chloroquine. Chloroquine is sort of the classic malaria prophylaxis that was used in probably since World War II. But certainly by the mid-1980s, most parts of the world had falciparum malaria. Again, falciparum is remember there's several species of malaria, but Plasmodium falciparum is the species that kills you, because it can infect red cells of all age and can cause a high parasitemia. So most malaria endemic areas had strains of falciparum malaria that were resistant to chloroquine by the mid-1980s. So chloroquine is really reserved for Caribbean, parts of Central America, and a few other isolated areas. So I've been doing travel clinic the last few weeks, and I've seen a lot of people going to Haiti, and they get, and a lot of them have been on chloroquine, because it's one of the few parts of the world where it still works. I mentioned at the beginning how patients will often go to the internet before they come to travel clinic. So a couple years ago, I had a woman who was pregnant, who was going to Uruguay, might have been Paraguay, but and in general, we don't recommend that travelers who are pregnant go to malarious areas if they can, unless they can help it, because none of the 3 options are safe in pregnancy. And I started to tell her this, and she says, "Oh, Dr. Armitage, I looked it up. There's northern Paraguay where I'm going is chloroquine sensitive." And I said, "I'll be right back." So, and she was right. So this, so there's parts of the world. So chloroquine is still a standard in Central America, north of the Panama Canal, and in the Caribbean, and that's pretty much it. There's a few other isolated areas. The 3 other options are methylquine, doxycycline, and malarone. I think I have. So methylquine was the big alternative to chloroquine, starting from the mid to late 1980s. And in some ways it's an attractive drug, in that it's pretty effective, and it's weekly. So taking a weekly drug is pretty desirable if you're going to be in some place for a long time. The problem with methylquine is that there's a lot of neurologic side effects. I mean, anybody in the room taking methylquine? A few of you. So, yeah, so almost everybody who takes methylquine gets vivid dreams. And you've talked to a lot of travel doctors. Some travel doctors love it. It's like LSD for travel doctors. It's really a great experience. Some people hate the vivid dreams, they're nightmares. But then a higher percentage of compared to other medications, a fairly high percentage of people have more serious adverse reactions, and it tends to be age-related. So the older you are, the more likely you are to have an adverse reaction. And these can be from dizziness to disorientation to psychosis to depression. So there's some pretty prominent faculty members in Department of Medicine who've had severe adverse reactions to methylquine. Blamed me for it. Again, this is an old story that during the war in Somalia, some Canadian soldiers abused prisoners, and they got off saying that the methylquine clouded their judgment. There's been individuals admitted with acute psychosis to inpatient psychiatric facilities where it was all due to methylquine. Methylquine stopped, psychosis resolved. So there's some serious potential adverse side effects. Now, Dr. Yadavali says that methylquine is the official malaria prophylaxis of Cassini trips, by the way. And most young adults do okay with it. Right. Most young adults do okay with it. And my use of methylquine really now is restricted pretty much to people who are young adults or people who've taken it before and not had a problem with it. And it's not only these adverse events. There's a lot of sort of scuttlebutt among like Peace Corps workers who've taken it for a year. You feel like they kind of get like a chronic fatigue syndrome from methylquin. I don't know, Peter, if you have feelings about methylquin, but yeah, yeah. Yeah, 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 yeah. It's yeah. There's literature in like Condé Nast Traveler about methylquin. A lot of patients come to travel clinic going, "You're not giving me methylquin, no matter what you say." You know, we're going to force them to take methylquin. So, once a week is yeah. Diarrheal, yeah. Well, it's funny because I mentioned this to a traveler today that methylquin is contraindicated in pilots. So pilots cannot take methylquin because it's supposed to interfere with your special judgment. So I saw a surgeon today who was going to be doing microsurgery, and we decided methylquin wasn't a good idea. Yeah. So doxycycline is a pretty good option. It's by far the cheapest. It's effective. The trouble with doxycycline is you're giving doxycycline to someone who's going to a tropical country saying, hey, oh, by the way, this medication is associated with sunburns. So that's the real problem with doxycycline. It can also cause vaginitis, diarrhea, maybe give you a little bit of protection against, in some cases, traveler's diarrhea. But it's not bad. And actually, I think more and more people like doxycycline because they're afraid of methylquin. They can't afford Malarone, which I'll talk about next. And so doxycycline, you know, if you don't get sunburns, it's pretty much okay. It's on the free list at Giant Eagle. It's one of the 10 drugs. So the drug I like is Malarone. And I remember, I went to the ID meeting. I think it was 2002, after Malarone had been approved by the FDA in the United States, and it was kind of like Malarone, you know, because everyone's like so excited. That's why it says Malarone. It's a really great drug. It's very well tolerated. I mean, the incidence of adverse effects is pretty low. It's very effective in preventing malaria. It's actually not bad for treating malaria. There's some disadvantages, but it's not bad. The disadvantage is it's inconvenient in that you have to take it every day, which for a long trip is a problem, and it's very, very expensive. So it's like $8 a pill. And so I was talking to somebody today, I don't know who it was, because I saw several people going to Haiti today. I think someone going to Haiti for 8 days, they had priced it out, and their copay was $192 for methylquin. But the other convenience advantage is the way it's dosed is you start at 1 to 2 days before you're exposed to malarious area, and it's 5 to 7 days after exposure. So someone who's going for a week, who can afford it, it's really good because you start it the day before you go, once you're there, and especially for business travelers. I mean, business travelers don't want to be taking methylquin when they're giving your PowerPoint presentation on this new electrical plant in Dubai, and they start hallucinating. That's not good. Not that I'm saying any bad things about methylquin. So I'm a big fan of Malarone. It's just the expense issue is tough, especially for longer-term travel. It's a good solution. It's a really good solution for people who are going someplace where they're not sure what they need. For instance, I've been to Laos and Cambodia, and most travelers to Laos, who don't need malaria prophylaxis, but there are some areas of Laos that you may need malaria prophylaxis. People aren't sure when they go if they're going to be visiting these areas. You got weekends off from what you're doing there. So it's a good medicine to take with you because you can just start the day before if you're going to go to a malarious area. So one of our residents recently went there and went to Angkor Wat, and there's an indication, for malaria prophylaxis for that little slice of time, and that's a very good. Again, doxycycline you got to take 28 days after you leave. 28 more days of a drug that causes sunburn. Malarone is 5 to 7 days. What's that? Yeah, exactly. If you're coming back to Cleveland, no worries. So there's a couple There's some alternatives that, especially people in Europe and Africa, use. There's chloroquine proguanil, which I'm not a fan of. There's the artemether compounds, artemisinin derivatives, which are not drugs for prophylaxis, and this is more of a talk on prophylaxis in travelers. It's great for treatment. These are they're fantastic drugs for treating malaria, not available in the United States, not FDA approved. But they're really a big breakthrough for treating malaria, particularly because they can be given PR in kids. You don't have to have an IV, you don't have to have PO. I've seen a couple travelers, I don't know how much people in the audience have experience with malaria. These drugs are famous for rapidly clearing parasites, but then having a high relapse rate. So we had a woman on the Carpenter team a couple years ago who was in West Africa, got malaria because she stopped taking her mefloquine, got one of the artemether compounds, defervesced within a day, came back to Cleveland, and then relapsed with malaria, kind of classic, So, and we gave her Malarone. The other thing I didn't mention about Malarone is the prophylactic dose is 1 pill a day. The treatment dose, full treatment dose, is 4 pills a day for 3 days for falciparum malaria. If you have non-falciparum, you have to take proguanil, the terminal prophylaxis. Another way to use Malarone for travelers, and this works well for physicians, say if you're going to Africa, you don't want to take doxycycline, you don't want to take mefloquine, you don't want to take Malarone every day, you can have a treatment dose of Malarone, and if you get a febrile illness, self-treatment with Malarone, 4 pills, and then get a smear and get worked up. That's a pretty effective strategy too. I think that's what some people work in Uganda do, because they just can't take mefloquine, they can't take doxycycline, month after month. So it's not something you would recommend to the average tourist, because you don't want them getting malaria and self-treating. But Malarone is very effective and very well tolerated. Yeah. I mean, if you can get it paid for, it's really good drug. It's safe. The other big thing about malaria compounds is that there's a lot of studies that show it's very unreliable to buy them in country. So you think, okay, I'll go to Malawi, and when I get there, I'll go to the drugstore, and it's over the counter, and I can get some Malarone. And studies have shown that bioavailability and what's there is just not reliable. So big pitfall for travelers is to buy drug in country. I guess the artemisinin compounds you have to. Can you get it in Great Britain? Yeah. Any other questions on malaria in travelers? What time is it getting to be? Oh my God, it's getting late. Sorry. Every traveler I see warn about dengue. Again, dengue is the McDonald's of diseases, more than 6 billion served. Dengue is spread by the Anopheles, Aedes aegypti mosquito, not the Anopheles mosquito. The Aedes aegypti mosquito is adapted to urban areas. Like in South America, Central America, malaria is rural. Dengue is urban. Dengue is everywhere. So you got to avoid getting dengue. Dengue is an illness in travelers. It's less serious than in natives. It's the opposite of everything else. Dengue is an illness where repeated exposures are associated with more serious episodes. The first episode is usually just a bad case of the flu, but still we want travelers to avoid getting dengue. A lot of dengue and chikungunya in South India in the rainy season. The only way to avoid getting dengue or chikungunya is to avoid mosquito bites. That's it, no vaccine. I think I'll stop there because I think that's most of the travel stuff. Does anyone, because it's 7:20, does anyone have any questions? Or comments? Or nothing? Okay.
I had a patient recently that I saw that she was asking me about prophylaxis for HIV. She was going to Haiti and she's an OB nurse and she was going to work with veteran babies who get at risk for exposure to HIV.
So that's a pretty specialized question. The question is about post-exposure prophylaxis for HIV, particularly a healthcare worker who is going to be providing medical care to high-risk HIV patients in a situation, and that's a. I think that I would approach that like any other post-exposure prophylaxis. There's probably the standard cocktail, and to take in case you were exposed. I mean, that's a whole other issue about how because some people perceive that post-exposures is effective. People have been engaging in high-risk behavior and then taking post-exposure prophylaxis, which, it's a whole other story. But for healthcare workers, I think it's probably, I I would assume in a parts of the world that are endemic for HIV, and you're part of a healthcare team, you should have the standard drugs for post-exposure prophylaxis. I would think that'd be good. Yeah. So. Okay, great. Thanks for your attention, guys.